Good evening. My name is Sultan Shakir. I use he, him pronouns, and I'm the president and executive officer at the Mazzoni Center. And first, I want to thank so many of you for joining us this evening to talk about a critical health issue for our community, monkeypox. This event is a collaboration of so many organizations who know that access to information is critical to keeping communities safe and healthy. So I want to thank State Reps Malcolm Kenyatta and Brian Sims, along with ACT UP, the Attic Youth Center, Bebashi Transition to Hope, Black and Latinx Community Control, Bread and Roses Community Fund, Colors, galaei, Independence Business Alliance, Mayor's Office of LGBTQ Affairs, Self Inc., SEIU Healthcare Pennsylvania, and the William Way LGBTQ Community Center. We have an amazing panel of speakers who have joined us today, and we know that you, the community, also have questions. If you have questions, please feel free to put them in the chat, and we'll work to get to as many of them as possible throughout this evening's panel. First, I want to thank one of the leaders in the response to monkeypox, Representative Malcolm Kenyatta, and invite him to join us.
Thank you so much, Sultan, and to Larry and your entire team at the Mazzoni Center. What you always do as one of the community anchors to keep folks safe and healthy, and what you all are doing in this moment is critical. And I just want to say thank you. I think I also saw Council Member Squilla jump on the call. I want to thank him as well. My message is just very quick, very simple, because I want us to spend as much time tonight hearing from the medical professionals. We need vaccine. We need it as quickly as possible. We need to make it as easy as possible for people to get it. And that's my commitment, the commitment of our colleagues, to continue to raise the alarm and speak to federal, state, and local partners to get the vaccine to Mazzoni Center and hopefully physicians all across the Commonwealth, so that we can keep people safe. And so I'll stop there and just say thank you again.
Thank you. I appreciate that. And Councilmember Squilla, if you are here and would like to say a few words, please let us know. We would love to hear from you. And thank you for your leadership in this work as well. I'd now like to invite two providers, Dusty Latimer from the Mazzoni Center and Sabrina Tate from Bebashi, to join us. Dusty, can you introduce yourself, tell us a little bit about the work that you do, and also what the community has been seeing when it comes to monkeypox? And also, before you do that, I just want to extend a big thank you not only to you and all the providers at the Mazzoni Center, at Bebashi, and elsewhere for everything that you do to keep the community safe. I think one thing that COVID has reminded us of is that it's providers like you that really take care of the health and well-being of our community, and that's so important. And so I want to thank you for taking on this additional challenge that none of us saw coming. We all thought we were coming out of COVID, we were developing the new normal, and here's something else. And so thank you for the work that you do, and again, the work, Sabrina, that you and your staff do on a day-to-day basis, keeping everybody safe. With that, Dusty, please tell us a little bit about yourself and what folks are seeing.
Yeah, thank you, obviously, to everybody here. So my name is Dusty Latimer. I'm a physician assistant. I use he, him pronouns. I work here at the Mazzoni Center, where we do kind of like, an LGBT focused full family practice. Over the past few weeks, obviously, we've been seeing, the way I'm thinking about it is there's two different kind of patient presentations. We're talking to a lot of people about getting vaccine, and we're talking to a lot of people about having this condition, about having this virus. So first, we'll talk a little bit about the people that we're already seeing with the virus. These are people who have, of course, we see on the news, we're getting a good amount of coverage about symptom presentation, about the way that this is affecting people, about what we can expect. One of the things that I really want to drive home, kind of jumping back off of what Rep. Kenyatta was saying, is like, let's raise an alarm a little bit here. This is very painful. This is, people are really afraid. There's a fear factor. There's a huge stigma factor, which we, at large, I think everyone in this group is kind of doing our best to kind of fight the stigma component, but it's there. And people are feeling isolated who are presenting with these symptoms. we're having trouble. We're hearing of trouble getting people in for testing. Access to testing is something that we're really, kind of at the Mazzoni Center being extra careful to pay attention to. And I know throughout the community, people are doing the same. We've been working really, really wonderfully with the Department of Health to get testing, to get those results, very, very quickly, sometimes next day results, and to get medication. Access to medication has been another huge component to this. And while those internalized workflows, here are going okay, and at other centers are going as they can, the overarching, this is the reason for the alarm. And now we have to figure out a way to get that vaccine so that we, don't continue to see these cases, and so that these numbers don't continue to rise. We're seeing an increasing demand for the vaccine. We have been lucky enough to be kind of designated as a vaccine site, and we are, rolling out and vaccinating very, very quickly. For each allotment that we're getting, we're going through it just as quickly. But we alone are not going to be enough as one organization within a huge city, within a kind of expansive community. So I'm so glad to have everybody here today, kind of talking about this. Yeah, I hope that answered.
Thanks, Dusty. And so, Sabrina, I've had the pleasure of working with you, and I love not only your leadership, but the work of your organization. And so I want to thank you for partnering with us today. And can you tell us a little bit about Bebashi and what your clients have been saying and experiencing?
So I want to say thank you. Thank you for allowing us to have a voice that has often been silenced. I think that, in the past, we've been seen as a competitor, but we really are serving a community, and we stand in alliance in doing that. Not only are we serving them, we're teaching, we're educating, and we are treating. We are providing prevention, and we stand linked arm in arm in doing that. So I thank you for inviting us to participate. So obviously we provide services to people who are HIV positive. We provide case management services. We provide prevention services. We do lots of education outreach. We deal with housing insecurity, food insecurity, and we have a wellness clinic. And what we see presented at our wellness clinic is panic. There's a lot of fear because of a lack of information. People are afraid because of a history of a lack of information regarding vaccinations, how it interacts with other vaccinations. Do they have to get a booster if they get this vaccination? Where can they go to a trusted physician or a trusted clinic and obtain these things? They are finding that the places that they trust and the people they trust may not have access to it. And so they'll wait rather than go somewhere where they don't have a relationship. We have a lot of questions around, where did this come from? How do I contract it? So I think that as much as we need the vaccination, because we certainly do, and we need to push and make sure that people are getting it, we also need to make sure that our voice is one voice, and that the information is sound information, it's vetted information, and it is clear information that is understood by all. So again, we're here. We certainly want to be able to support the community, and we want to be able to have one voice in doing that.
Thank you, Sabrina. And I'll say, as the president of Mazzoni Center, I value the partnership that we have developed with not only Bebashi, but with a number of other organizations. And so I definitely hear and recognize that feeling of being competitors, and I'm glad that we are partners in this effort to really combat this. And before we move on to representatives from Philadelphia Department of Health, Representative Kenyatta. If there's anything else you would like to say, I would love to give you that opportunity now. If not, we will first thank you, Dusty and Sabrina. We will obviously have you back momentarily for questions, but if I could invite Jessica Kalm and Dr. Shara Epstein from the Philadelphia Department of Public Health. And thank you both for joining us. First, why don't we start with introductions? Can you tell us who you are and what you all do for the great city of Philadelphia?
Hi, everyone. I'm Jessica Com. I'm the program manager for public health preparedness at the health department. So most recently been working on COVID response, and now we've obviously shifted over to monkeypox response.
Hi, my name is Dr. Epstein. I am the medical director for the Division of Disease Control for the Department of Health in Philadelphia. I'm an infectious disease physician. And I just wanted to thank you so much for having me here today.
Well, thanks for being here. I mean, similar to the providers, no one expected this to happen, particularly on the heels of everything else that we're dealing with as a city. So I really want to thank the Philadelphia Department of Public Health for, the quick turnaround on this. And one of the things that we know is that we don't have enough vaccines. And so let's talk about that. So first, where are the current vaccines coming from and why don't we have enough?
Thank you. I can address that question. So the current vaccines are coming from something called the Strategic National Stockpile. And this is a stockpile of medications and different supplies that would be used in an emergency. A lot of the materials that are in that stockpile are really intended for terrorism events. And so the Jynneos vaccine that is in the stockpile is for both smallpox and it is also can be used for monkeypox. And so there is a limited amount of vaccine due to the fact that it is not a routine vaccine that is given. It's a part of the stockpile. And so there is just a limited amount of vaccine that's available through the stockpile. The allocations are being made by the federal government. Right now, the allocations, as I understand it, are being based on case counts. So it doesn't help us right now to get vaccine that we have lower case counts in some other jurisdictions. So that is not working in our favor. So it is a limited amount of vaccine to date. As of yesterday, we had received 2,625 vaccines total. That is a very small amount of vaccine. Today, we received our next shipment, which was 2,420 new doses of vaccine. And so we're in the process of being able to distribute some of that to providers. The health department will use some of that for clinics that we're also operating. And then we'll have an opportunity to order additional vaccines on August 15th. The total allocation right now that we are drawing down from is about 6,000 vaccines. So again, that is not a lot of vaccine. The demand is much, much greater than the supply. We have seen this before. And so we really need to continue to advocate for more vaccine. I know our commissioner has been reaching to the highest levels of government to strongly advocate for more vaccine. And I do hope that we will see more in the fall, but right now it is an extremely limited supply.
And thank you for that. Given that it's in limited supply, the question that most people have on their minds is, how can somebody get access to a vaccine, particularly if they're not a client of one of the centers that has been given the limited supply? Can you also answer the same question for testing and treatment? Where can people go for testing? If they believe they have monkeypox, where can they go for treatment?
I'll start with the vaccine question, and then I think I'll defer to Dr. Epstein to talk about testing. So for vaccine, we have a couple of things happening right now. We have some providers who have been identified as providers who work very closely with the high-risk community. And so those providers are receiving vaccine from us. So we have a group of 4 that have received vaccine so far. Another 4 are queued up to receive vaccine. And then there will be conversations happening with another 4 who also would be appropriate for distributing vaccine. So we're just getting this process up and running to get vaccine out to providers. Separately, the health department has been running vaccination clinics at William Way Center as well as at Health Center 1. Right now, because the supply is so limited, we are only able to do vaccinations by appointment only. We are unfortunately not able to take walk-ins. And so scheduling has been occurring through the health department's call center. We can share that information after this call if that would be helpful. But again, we know that the vaccine supply is very limited and we are not able to provide vaccine to everyone who's looking for it at this point.
And so if somebody, just for those who are on the webinar, if somebody is interested in getting a vaccine, what is the first thing that they should do?
I think they should review eligibility for who in Philadelphia can receive vaccine right now. We can share that information out with the group. So there is some eligibility criteria because we really do want to make sure vaccine is going to people who are most high risk. I would particularly emphasize that we keep vaccine in reserve for people who may be contacts of cases. That is the highest priority group that we want to make sure are vaccinated. We are also trying to identify people who may be in social networks of contacts to offer vaccine. And so I think the best thing to do is for people to review eligibility. They can contact the health department through our call center to see about scheduling an appointment at one of our vaccination clinics, and also check with their own provider to see if that provider is offering vaccine right now. But again, that's going to be a very limited group. Dr. Epstein, do you want to add anything to that?
No, I just, well, I want to just repeat that, you know, we're advocating for more vaccine. We know it's not enough and we want more. We want to be able to give it to everyone in the community. I think that's it on the vaccine. We just really, we know certain people want to get it from their providers. Certain people feel much more comfortable with providers, which is one of the reasons we so quickly moved to providing vaccine to providers this time with monkeypox, but also, you know, maintaining our public health clinics for those that don't have a regular provider. Yeah. And then as far as testing and treatment, I know this is another, you know, a big concern, and in some ways it feels like, how can we be back here again? I, you know, want to say that this is different than COVID in a lot of ways. The testing is not difficult, and it's now commercially available. So any provider can order the test and can do it in their office. It certainly, unfortunately, requires PPE and some materials, but those are available now. So we're encouraging providers to open up testing more widely. Everyone's and we're also offering PPE and supplies to some providers to help with that. And then I can speak to treatment too, but I'm not sure if there's any questions about testing. Treatment, so there's a couple treatments, but the main one that people are hearing about is tecovirimat. And unfortunately, it's still under a process called IND, an investigational new drug. The federal government, the CDC and the FDA have shortened the process considerably at the beginning. Some of the providers on this call might know that at the beginning, it was just pages and pages and pages of work and very hard to get the medication. It's improved again considerably, but it's not like prescribing any other drug, unfortunately, at this point. And that's because, you know, the CDC, the FDA really wants to get a lot of information about how this drug is working because it is a newer drug. So we are several providers in the city have been really great and have been prescribing this drug, even though it's been difficult. And we're happy to work with providers to kind of walk through those steps the first time and really help, because I know it's an intimidating process, but we do want to get the treatment to those who need it. Most people don't need treatment, but you know, it does seem to really help some people, and we want to make sure those people can get it.
Thank you for that. And for individuals looking for information about vaccination, testing, or treatment, particularly as it evolves, is there a place that they can go to get access to the current Philadelphia Department of Public Health information?
We have a blog post that summarizes some of that information, so we can share the link for that. And I think there will be more information forthcoming on the city website, but it's not quite all up to date yet.
Thank you for that. And so when we get that information, I'd love to invite Jasmine Henderson from ACT UP and Black and Latinx Community Control to join us. And hello, Jasmine. I obviously know about you and some of your work, but can you share a little bit about you, ACT UP, and Black and Latinx Community Control? And also tell us about some of the things that hopefully the community has learned, particularly after some of the challenges we've gone through with HIV/AIDS and then COVID when it comes to addressing our health.
Okay, so ACT UP Philadelphia started when the HIV crisis was first gaining speed. And through direct actions, pressuring big pharma companies, governments, we were able to get people medication, HIV medication, to extend their life to the point where now, like, you pretty much live a full, normal, healthy life being HIV positive. Black and Latinx community control of health just recently started up within the last 2 or 3 years. And our purpose is to make sure that Black and Latinx folks are at the table when it comes to making healthcare choices and decisions that matter with our health. All too often, you have doctors, CDC, everybody else deciding what's best for us, but our voices aren't being heard. And we decided that that was no longer acceptable. As far as what we hope the community learned, it don't seem like that. I mean, like, community as in our folks, we've learned a lot. That's one of the reasons why it seems like the CDC and the government is taking the approach that they've taken with who they decided are the high risk groups, right? Because due to HIV and all of, and what happened with that, a lot of LGBT, especially men who have sex with men, are more health conscious. So when we see stuff that don't look right, we're quick to go get checked out and make sure that everything's okay, which is why they're catching so much of the monkeypox infection in that particular population. But I was hoping, at least by the time that this call happened, that the CDC, public health departments would have started shifting that narrative and started pushing back against government, against federal government or whoever's setting the rules as far as who's being tested and who's treated as high risk. I noticed that they were very careful to not say who the high risk populations were, and you can look this up and you can look that up. But in all actuality, from the research that I've done to get tested, to even get tested for monkeypox, like, you have to be LGBT or trans or gender non-binary, right? And then, like, the next requirement is for you to have had some kind of STI in the past couple months. Monkeypox is not a sexually transmitted infection. And for it to be being treated like this, they're gonna drop the ball again. By the time they figure out what's going on, they're gonna say that there was all of a sudden an explosion of monkeypox throughout the population, right? But we know that it's already here. You're just not testing everybody, so it's not being found everywhere. And it's really disheartening. And it seems like it's time for ACT UP to actually go back to some old tricks to get people to sit up and pay attention to what's going on.
And to that point of, what have we learned and what has changed? There's definitely some questions in the chat that I would love to get to that kind of get to that. If I could ask the panelists just to come back and we can answer some of the questions. The first one really is about access for people of color. Since 60% of cases in the US affect people of color, what is the Philadelphia Department of Health doing in terms of outreach to those communities, especially online and at sexual venues, such as the 2 bathhouses in town and several other places where MSMs meet?
That's a great question, and something that we are working on is developing a more comprehensive outreach plan. We have a list of venues and organizations that may be able to disseminate important information. And so we hope to put a canvas together that will happen, I hope, next week, where we'll be able to have staff going out and providing information, hopefully materials that can be distributed. So that is all in the works and hopefully can happen very soon. So it is a high priority on our list of things to do.
Thank you for that. And the next question is, Sabrina?
Yeah, I took myself off mute. Of course, I'm not a part of the health department, but we were birthed out of the HIV/AIDS epidemic, and our goal is to make sure that the Black and Latinx community are informed. So everything we learn as fact, we are teaching to people who are coming into our doors. We're giving them the information that we can. We are testing, and we look forward to vaccinating as soon as we have it in our hands. We want to make sure that, as Jasmine said, we're giving sound information to the people who need it, and that they can ask us at any point, even if we're not able to, we are able to treat, we are able to test. We are not yet able to vaccinate, but we have had conversations with the health department. We are in line to do so because we realize that we're a trusted facility. So we want to make sure that they're getting information from people they actually trust, given the mistrust and you know, the history in the Black community. Good question. Thank you.
Certainly. And to that question, or to that point of Bebashi at this moment not having access to vaccines, there is a question of, even to us, with all due respect, why does Mazzoni have a large amount of vaccines for their clients, but other agencies are not being given doses? Can I ask folks from the Philadelphia Department of Public Health to talk about how the allocations were done for vaccines?
I can speak to that a little bit. I apologize for the noise in the background. So allocations have been really based on identifying providers who are working with the community that we're looking to serve. And also providers were asked, if you had vaccine, how many people could you vaccinate in a week? And so we made allocations based on what we heard back from providers as far as how quickly they could move vaccine. I think the goal here now is, while we have vaccine, to get it out as quickly as possible. And again, working through providers who were able to do that. So that has been, you know, one of our initiatives. We have a lot of work to do here, and we really want to engage many more providers in this process. So that's basically how we've gotten started. One of the other things that I think we would like to do as a department would be to identify organizations that may be able to host us, to offer a health department run clinic, who provide a venue and would be able to have ties to the community that we're trying to reach, and can be trusted messengers for vaccination and build vaccine confidence and do all of those things. So that is something that we're definitely open to. Vaccine supply is, of course, very limited, but definitely something that worked well for us during COVID, helped us to address equity issues during COVID, and I think is a good practice that we can implement here, and certainly want to do that.
Thank you for that. And Jasmine, I see you have a hand up.
Yeah, she said Mazzoni was chosen because y'all worked with the population that they were trying to reach. And I continue to hear that phrase, population we were trying to reach. That is a roundabout way of saying what? What population are you trying to reach? Because Mazzoni is not the only population that works with LGBT folks. They're not the only population that works with Black and brown folks. They're not the only population, and this has got no slight to Mazzoni, right? But the Philadelphia Department of Health needs to come out and say that they're targeting places where there are LGBT people, because that's who they're looking at as being carriers and transmitters of the monkeypox virus. They're not looking at the whole population. They're not looking at the general population as a whole. And if that's what they're doing, then they have learned absolutely nothing from the HIV or the COVID epidemic.
Just to respond to that, I would say right now we are following the data, and we are looking at transmission and what the outbreak looks like, and trying to keep the vaccine as close to the virus as possible. And so that's why decisions have been made about which providers to work with. Right now, that may expand. I hope it will. I mean, we certainly want to expand offering a vaccine as we're able to, as the supply increases. The other thing I did not mention that I should also mention is that there are certain vaccine requirements that CDC mandates as far as storage and handling and reporting. And so providers also need to be able to meet those requirements as well. And that's why it does take a little bit of time to get new providers on board.
The CDC, Philadelphia Department of Health, those requirements, like it's all the same thing though. Y'all are still targeting one particular demographic of people when this virus is not an STI, it's not sexually transmitted, it's transmitted from skin to skin contact and contact on surfaces that have been contacted by people who are infected with monkeypox. So that does not limit it. And the fact that the federal government, the state government, and the city government are all limiting what they're looking at instead of using common sense is very frustrating and aggravating as an activist. And the stigma that this is creating for Black people, for LGBT people, for trans people, for gender non-binary people is going to be dangerous. And if it's not treated and if it's not looked at and done in a way that makes it equitable for everybody, you are literally putting trans people's lives in danger. You're putting LGBT folks like in danger because these nuts that run around here and only go by what y'all say are not going to use common sense and tamper it down when they think that we're the ones that's running around spreading this virus that's causing so many problems.
And to echo that with a comment that was in the chat, not a question, but a statement. We failed with HIV, especially with the Black and brown communities, with repeating the same mistakes with COVID. Let's learn from previous mistakes and not repeat failures. The feds must supply sufficient amount of vaccines. So I just wanted to read that out loud because it echoes the conversation being had now. The next question we have in the chat, visually, how do you differentiate between a diagnosis of scabies, herpes, and monkeypox?
Dusty, do you want to take that or should I?
I can say the way that we're approaching it at this point. We when somebody kind of contact via telephone or via our electronic communication, we actually ask them to send us electronic pictures. And even with like really good like smartphone cameras, it is really difficult to differentiate based off of an image. It typically does require people to come in for testing for us to make that differentiation. And I've definitely swabbed things that I was certain were going to be positive that weren't, and vice versa. So at the end of the day, this looks a little bit different in everybody that it shows up in. So the only way to really know is to get folks in and to get them tested.
Yeah, and I just want to echo Dusty there. We need to test people. We need to test more people. Some lesions, some rashes, the providers who have been testing have, they look typical. They look, people can, you can look and say, oh, I think that's going to be monkeypox, but we're also being surprised every day. So we really need to test widely, and we need to encourage, again, more providers to test widely. Testing is not limited. There's laboratory wise, the labs have plenty of capability to receive the tests and run the tests. So, anyone with a rash that could be monkeypox should be tested, and it shouldn't be limited to the LGBTQ community or anything like that.
To echo what you all said, that is our practice. When we see something and there's any doubt, we test for everything because we want to be on the side of correct and right versus, making any assumptions.
And I'm sorry, I just wanted to add one more thing. Thank you. Some of these lesions, they can be very subtle. People come in saying, oh, I think it's just my normal acne. And they're testing positive. So really, sorry to jump back in, but really encouraging more people to seek out testing and providers to do it, of course.
The next question is about how people stay safe. Is monkeypox aerosoled? And if so, how might business owners best protect their staff, receptionists, wait staff, etc.?
So monkeypox is not nearly as transmissible as COVID and lots of other respiratory viruses. We're not seeing transmission in, casual kind of settings like, among restaurant staff, for example. It's really very close, intimate contact, and the vast majority skin to skin contact.
Thank you for that. And so there are some questions around resistance. One is, if we were vaccinated against smallpox as children, is that vaccination still valid today against monkeypox? And then there's a slightly similar question. I'm a few months shy of 65. I've read conflicting reports about what kind of resistance I might still have from being vaccinated for smallpox as a child. What are your thoughts? And also, would I benefit from receiving the monkeypox vaccine with increased immunity?
Yeah, that's a really good question. I think a lot of people are asking. I was asking that question recently too. We have heard around the country, around the world, of people who had received their smallpox vaccine 20, 30, I think it was 1972, we stopped vaccinating, so 30 years ago, and have tested positive for monkeypox now. So people who received their smallpox vaccine that long ago should still receive their Jynneos or their monkeypox vaccine now. There's a small subset of people that have continued to receive smallpox vaccine. Certain people in the military, certain laboratory workers, and if those people who received their smallpox vaccine much more recently are probably well protected against monkeypox.
Thank you. Next question. What is the likelihood of second doses being offered at the 28-day mark?
Jessica, go ahead.
Take that one and you can jump in if you want to. I think at this point, given the limited amount of vaccine that's available, our approach has been to administer single doses, and that we hope to be able to administer second doses at some point when we have more vaccine availability. It probably will not be at the 28-day mark, because we really are trying to vaccinate as many people as possible. With the vaccine allocation that we currently are in the process of receiving, those 6,020 doses, if we use all of those doses, we can give 6,000 some people one dose of vaccine, give them some protection, versus only being able to vaccinate 3,000 people. And so that would really limit our response effort. My understanding, and Dr. Epstein can jump in on this, is that there is no contraindication for receiving the second dose at some point after the 28-day vaccine, but I'll let the clinicians answer that question.
Yeah, that's absolutely right. As with most vaccines, you don't want to give it too early, because you want to give your immune system that time to really build up. But you can always give the vaccine late. And we wish we had enough to give it in the 28-day time period, but the available evidence, suggests that people will still get very good protection. And we really want to give more people very good protection than so few people, the full series.
Another question from the chat. So what are the recommendations around sexual practices at this time?
I'll jump in on this one. As with everything when we're talking about sexual health, it's a conversation around risk reduction, and kind of ways that we can reduce the risk here. Obviously there is no no risk scenario. But we can, I've been really openly talking with my patients about limiting sexual networks, about having conversations with the partners that they have, and just, kind of what we can from like a community grassroots point, like, spread information, talk about who has been vaccinated, who has questions, who has, had some symptoms, and just kind of keep conversation open within our sexual networks. We do also know that there is definitely, and obviously we say limiting sexual networks as we can, knowing that always isn't a complete, we can't always do that completely. But using barrier protection is something that will reduce the potential here. So, condoms can absolutely help.
I'm confused with that. If this can be spread by skin-to-skin contact, how does a condom prevent that?
But it is kind of most effectively spread, from skin to skin, in which there is, in which symptoms are present. So if part of that tissue is covered, it can reduce it. it doesn't, we can't ever say that, a condom is absolute like prevention for spreading monkeypox, but it does reduce it.
I don't understand how, if the person has monkeypox, and if one partner has monkeypox and the other partner doesn't, and they have sex, their skin is touching. The only thing the condom is preventing is the skin touching on insertion, but the rest of their bodies are still going to touch. So it's still spreadable. This still sounds like a stigma spreading conversation to me. Like, we're not dealing with the fact that the issue is this is skin on skin contact that spreads this. A condom prevents sexually transmitted infections from being spread most of the time. This is not a sexually transmitted infection.
It is not, but it is very effectively spread through sex. And in the cluster of cases that we are seeing with this outbreak, there is a disproportionate involvement of genital tissue. So we are seeing a lot of genital, a lot of anorectal involvement of this outbreak.
Because you're targeting men who have sex with men. You're targeting trans and non-binary people. So you're targeting people where this is the kind of sex that they have. It's a confirmation bias that is ridiculous. Because if they were testing and targeting heterosexual people this way, you would probably find just as big of a spread.
I can't speak to patients that I'm not seeing.
So the next question is, should I get tested before getting vaccinated if I have concerns about having monkeypox exposure?
Really good question, because this is different than a lot of other infections that we've dealt with. The vaccine in monkeypox can actually, when given after exposure, can actually prevent the disease. So very different than, your flu shot, your COVID shot, things like that. So there's really no tests right now that we can do to test unless you have symptoms. But as long as if you were exposed and don't have symptoms, that's the perfect time to get vaccinated. And that's that's why we have to save a little bit of vaccine behind. We can't give out every dose because we need to be able to vaccinate those people who were just exposed. And ideally within the first 4 days after exposure, but up to the first 14 days, we can really either prevent infection or decrease symptoms significantly. So no, you don't need to get tested if you don't have symptoms.
And in terms of exposure, someone noted that experts have pointed out that the vax-only approach to COVID has been detrimental to our communities, especially communities of color and vulnerable populations. Why is the panel recommending a vax-only approach to monkeypox? Does the panel have recommendations for other mitigation strategies? Also, can the panel talk about both monkeypox and COVID since we are at risk of both?
I can start. And yeah, so I think that's true. Vaccine is not the end all be all. Unfortunately, it's amazing. It's wonderful. It's great that we have it. But as we all know, we don't have enough of it right now. And nothing's 100% perfect. So, there are other, measures we can take, like some of the things that Dusty said, limiting sexual networks, and, just limiting very close social contacts, skin to skin contacts. And then making treatment more readily available for people that do get monkeypox, because people are going to get it. It's a virus. It's going to continue spreading, and we want to make it as, it's not going to be a good experience, obviously, but we don't want people to suffer, and making treatment as available as possible, getting people in who need treatment early, because again, like many viral infections, treating early is probably going to make a bigger impact than treating later. So getting those people in to get treated is another, key in this fight against the virus.
We have another question about protecting oneself. What can a person do on a daily basis to better protect themselves from risk of infection?
I mean, that's a huge question, right? I mean, like it's close contact, right? And it tends to be a little more extended close contact. So again, like the conversations that I'm having with my patients are about paying attention to the kind of daily risks that we're taking and, I don't know, limiting what we can.
And kind of like COVID, we knew about things like cleaning surfaces and other things like that. What are other preventative measures that individuals can take when it comes to monkeypox?
If you live in a household with someone who has monkeypox, trying to separate from that person as much as possible. If you share a bathroom with that person, cleaning the bathroom in between people using it. And just generally, keeping high touch surfaces clean, but and covering lesions, if you do have lesions, can help prevent spread to other people. But there's really, there's no special cleaners for this. Typical kind of things that you use to clean your households are appropriate for monkeypox. So, continuing to wear a mask, there's really not a lot of respiratory spread, but to be extra careful and also prevent yourself from getting COVID in the meantime can't hurt. Those are some of the kind of things you can do.
And we have a question about caring for people. Are there any mutual aid or volunteer efforts set up to support folks who are ill and isolating? I'd like to connect with those efforts if they exist. It seems like a lot of people will need help with interrupted incomes, errands, etc. I'd love to see a bigger government effort to support people who are isolating, but I'm not holding my breath.
That's a great question and comment, and something that we started to discuss internally today. So I don't have an answer for that today, but something that we recognize that if a person has to isolate, has to be out of work, that could be very disruptive. And so something we need to consider and see what we can do as we did some things for COVID. So don't have an answer right now, but something that we will take back and continue to work on.
And to go back to the point of limited vaccines and how different agencies are selected and individuals are selected, there are two questions. One is, I was chosen by the health department for a vaccination clinic. How was I identified?
There are a couple of mechanisms that we have been using to contact people. One has been contacts who may be identified by cases, and so they are contacted by our call center. We have also been asking contacts to identify people that they might recommend for vaccination due to connections through social networks. And then we have also issued some invitations out to individuals that we're drawing information from some of the databases that we have in the health department. I don't have all those details in front of me, but some of the invitations have gone out that way for people who may be more high risk and not know it. So that's basically how those invitations have been going out. We are also, for people who want to be vaccinated and want to self-refer, our call center has also been making those appointments based on eligibility. So a couple of different mechanisms for connecting people with vaccination right now.
And another question about vaccines. If the vaccine is not provided after infection, what is the treatment after exposure and how effective is it? And finally, are there side effects to the vaccine?
So, good question. So if a person is exposed and doesn't have any symptoms, vaccine is the best thing. And by exposed, we really mean, skin to skin contact. And that can be sexual, that can be, social kind of dancing or other kind of close skin to skin contact that can be taking care of a child. So if there's no symptoms after an exposure, vaccine is the best way to prevent infection. Once there's symptoms, then a person should be tested for monkeypox. And if, depending on a couple of factors, including the person's past medical history and kind of how bad the infection looks and the places where the person is really affected, a decision about whether to give treatment would be, discussed with that person. As far as side effects from vaccine, it's similar to other vaccines. And maybe Dusty's talked to more people after they've been vaccinated. But, fevers, chills for a day, swollen glands, stuff like that.
Yeah, it seems to be pretty well tolerated as from what I've heard so far. Yeah, just a little rundown a few days afterwards. And it's a subcutaneous injection, so we're not going into the muscle as deep as we typically do, but people are still winding up with a good amount, kind of a surprising amount of soreness after the fact.
Thank you. And there were a couple of questions just about language that was used. One, what is PPE? That's personal protective equipment. So when you hear PPE, we're talking about the gloves, the masks, the face shields, the full personal protective equipment that the doctors and nurses wear. Another question along those lines, who are the providers we keep talking about? We're talking about the doctors, the nurses, the nurse practitioners, the individuals who provide the healthcare with that. And we actually have a question about providers. Would also love to know why Mazzoni employees, and I'll say other employees who are also doing this work, in particular, the providers and clinical staff who are placing themselves at risk when swabbing patients are not offered the vaccines, as we're also a vector who could spread infection to patients and are exposing ourselves daily.
So I can say, I want to be able to offer the vaccine to all the providers, especially after all the work everyone's done in the past couple of years, putting themselves at risk. I would love to be able to do that. We have a few thousand vaccines in the city, and a lot of wonderful providers, including the emergency departments who employ hundreds of people. And we could use every single vaccine on those people that are doing the testing. And luckily, we haven't seen healthcare worker kind of transmission to healthcare workers to date. And the PPE, again, the personal protective equipment, the gowns, the gloves, the masks, really have prevented infection.
And can you get monkeypox multiple times?
No, we don't think so. So, and certainly not in any kind of short-term months to a couple of years.
And given the high amount of mistrust, how would you address vaccine hesitancy?
That's a great question, and probably everyone has something to say on that issue. I think we can talk about the safety of the vaccine. I think the clinicians can talk about that. I think one of the things that we need to do as a department is really to work more closely with some of the providers, some of the community organizations, and really try to get the word out about the safety of the vaccine, the protection that it offers, and just address any concerns and questions that people may have about this particular vaccine, since it is unfamiliar. It's not a routine vaccine. People probably do have a lot of questions. I know we have been collecting a lot of questions at the clinics that we're running that people come in and ask. We're trying to develop FAQs that really address some of the questions that are coming in. So I think we need to do broader distribution and just address questions and concerns and fears that people may have about this vaccine. But I'll let the clinicians speak more about that.
So, I mean, one thing of interest for me at this point, at least, is I have not within my own conversations seen the level of vaccine hesitancy that we're kind of we are kind of used to seeing around a rollout of a new vaccine. I think that the information that we're able to provide about safety And then, kind of concern around contracting has actually kind of motivated a lot of folks to kind of move forward and just get the vaccine when it's available.
And can someone talk about how being HIV positive impacts monkeypox or vice versa?
Yeah, so being HIV positive in and of itself, if a person is, undetectable with a good immune function, I don't think we've necessarily seen worse disease. Although that's, there's been a lot of cases, but not a huge number yet. So we're still, monitoring this closely. We think people who are HIV positive and immune suppressed with low CD4 counts have more severe disease. And, it's again, extra important to that those people be offered treatment for monkeypox.
And in terms of cases in Philadelphia, someone put in the chat, the last they heard 80+ people in Philadelphia are considered to have monkeypox. How many confirmed cases are there now?
Today, it's 84 cases.
And then there are some questions about protection. How long before the vaccine is effective after someone gets the shot? Yeah, and there's a similar question that basically asks the same question.
Yeah, that's another good question that I think we've all thought about a lot. So because the vaccine can be given as post-exposure prophylaxis after you've been exposed, that would lead us to believe that the vaccine is somewhat protective right away. But we have studies that show that there's that kind of your immune response to the vaccine is similar to your immune response to another older smallpox vaccine at 14 days, I'm sorry, post-vaccination. So we think that at 14 days, you probably have even better protection than immediately. Not very satisfying. There's still, not a lot of vaccine that's been given out in the country. So we're still learning and waiting for data on this.
And how long should you isolate after testing positive for monkeypox? And if based on resolution of rash, about how many days on average?
Yeah, good question. So it can be a long time. It is based on resolution of rash, and that can take a while, a few weeks, which is really difficult. And I think that question about mutual aid and other services to get people the things they need while they're isolating is really important and something we're really thinking about.
We have a question from somebody who has been vaccinated. I've been vaccinated. What can I expect looking forward in this situation?
So if you've been vaccinated, we think, you have very good protection. We want to get you that second vaccine as soon as we can. And when we have enough vaccine that we feel comfortable calling people in for that second one, we'll make sure there's a way for people to get their second vaccine. But yeah, I think, it's great if you've been able to be vaccinated at this point.
We have a few more questions that are coming in about how folks can find out if they have monkeypox. And there's also another question that is similar. How to go back to vaccine distribution, someone asked, how exactly are vaccines distributed? Who is accountable for vaccine distribution? As you recall, in the debacle vaccine distribution in Philadelphia at the onset of COVID, can you make this process transparent to the public?
One of the things that we have set up that just went live yesterday is a page, and again, I can distribute that link that is on our acute communicable disease webpage, part of the city's website, that is actually sharing information now about how many vaccines the city's received, how many have been distributed, how many are with providers. So I think we can have more transparency on what the allocations are and what the inventory looks like at any given time. I'm not sure if information has been shared about which providers have received vaccines. So I need to take that back to the office to see if that's been released yet or if it will be released. And again, the federal government is making decisions about how much vaccine Philadelphia gets based on case counts and I think some other parameters. Once we get vaccine, we're making decisions about providers who can quickly move the vaccine, who are able to reach the population that we're trying to reach so that we can make sure that the people who need the vaccine are getting it. That's a list that is going to continue to expand as more vaccine becomes available. And it really is based very much on what providers tell us that they can do in a week. And once they've moved through that vaccine, we try to provide additional doses. So it is a very fluid process right now, just given the very limited availability of vaccine, and something that we hope to expand as the vaccine supply increases.
There's a question around the LGBTQ community and the broader community. Gay and bisexual men do not live in vacuums. They live in with the intersections of many identities, as well as maintain varying levels of proximity to the cishet communities. How can we disseminate information to the LGBTQIA+ population while keeping other communities vigilant?
That's a great question, and we would love to hear input from people about how the health department can distribute information, what information needs to be distributed, how it needs to be distributed. I think that's all input that we would love to hear. And I'm hoping that with the group that's been put together here, panelists and other organizations, that is feedback that we can take, and that we can hopefully improve communication, get information out more quickly. We are developing a communications and outreach plan, but it's really important that we get feedback on what we're doing so that we make sure that our strategies make sense and that we're getting out information appropriately and in a timely fashion. So I think that's still something that's in development, and definitely looking for feedback from participants, the panelists and other colleagues who are able to better direct and inform what we're doing. And I know that other conversations are happening with the health department and community organizations and advocacy organizations and providers that I hope will really help inform what we're doing, and so that we can be more transparent in information sharing and really be more timely in all of those communications. So it is a work in progress, but one that I hope we're going to take great strides in over the next couple of weeks.
I will say, I hope I speak for many providers when I say that we are ready. We certainly want to make sure that the people that we serve are protected. We want to make sure that we're protected. So we will be a distribution center of information as well as any protective measures. And we want to make sure that we understand how this is transmitted, what the expectation is on quarantine times, what to look for, so that not just the physicians, but the people who actually work with the community every day can give this information in a way that is understandable, that's digestible by people that they trust. Having this information come from a TV screen with someone who doesn't look like you, who doesn't walk your walk, who doesn't live the same life that you live, is not a reality to them. What's a reality to them is getting information from people who actually live where they live like they live, and they come without the judgment of a stigma that's attached to a diagnosis. So making that information available and culturally sensitive is something that we're open to receiving and disseminating.
What you just said was beautifully put, Sabrina, right? The stigma. And I've noticed that every time I brought up anything, with just the Department of Health and the stigma around how they're currently doing things and what that is creating, nobody has had anything to say, right? They keep going back to this is what the CDC guidelines are, and it doesn't make sense, right? I get what people are saying the guidelines are, but we know what the science is. We know what common sense is. And to literally be basically putting this off on trans and LGBT folks, and they're the high risk population, right? Like even and I don't fault Dusty for what he was saying about the condom use, but saying use a condom to prevent transmission of monkeypox makes it sound like it's a sexually transmitted infection. Targeting a group of people based on who they love or who they sleep with makes it sound like it's a sexually transmitted infection. Everything that I've heard coming from city officials has made this sound like it's a sexually transmitted infection, and we know that it's not. And it's very frustrating and aggravating, and it's not going to promote any kind of trust in any of the Black and brown communities when they won't even admit that it's not what they're playing it out to be. It's gonna make hesitancy to get the vaccine more. It's gonna make people go to get tested less. And the lessons from HIV should have taught us that if this is one of those things where the sooner you're tested and the sooner you're treated, stop making people feel bad and not wanting to go get checked out. Because there are some people who will just sit in their house for a month until the rash goes away and they feel better and never get treated or never get vaccinated. And this is gonna happen. People are gonna die. Monkeypox has a 1 to 10% mortality rate, depending on different extraneous factors. So people are going to die from this, and ignoring the fact that it's not just based on one particular demographic of people is gonna make it worse. And who's gonna suffer for it in the end? We are. Because we're being targeted as the community that is at risk. We're being targeted as the community that could possibly be the infection vectors. And in a time when we're already being targeted for so many other things that are beyond our control, this should not be happening.
I appreciate all of that, Jasmine. I thank you for that. I think that, you know, as a provider right now for the LGBTQIA community, you know, of course, not exclusively, but very, very disproportionately, the position that I continue to find myself in is, you know, obviously like lessons learned from HIV and wanting to make sure that we're avoiding stigma and wanting to make sure that we are talking about this not being only a sexually transmitted infection. And then on the flip side of that, making sure that the very limited quantity of vaccine that we have are being earmarked specifically for, you know, for folks within the LGBTQIA population disproportionately, because that's where, you know, maybe a little selfishly, but that's where I want those doses of the vaccine to go right now, is to protect our community. So it's a difficult balance, but, you know, I'm well aware.
But if we're going to protect the communities that are most at risk, the people that should be being protected first should be sex workers, because they are especially those who are doing survival sex, because they have no choice in whether or not they can have that close contact. Homeless people should be getting vaccinated first because they're out here in the streets. The city won't do nothing about putting them in a place where they're safe. The least they could do is make sure that they are protected from as many viruses and deadly pathogens out there as possible, right? There's a question in the chat about what I would do. And what I would do is I would start with the populations who are always at risk for everything. So Black and brown folk, homeless folk, poor people, sex workers, these would be the people that I would be out here talking to, because these well-to-do folks who can get sick and sit out of work for a month and not miss a beat, they're not the ones who are at risk. It's those of us who are considered essential workers, it's those of us who are on the front lines, always working with people who are always at risk, that are the most at risk, and the ones who are usually the least able to do what we would need to do to take care of ourselves.
I agree, Jasmine. I think that, educating in the meantime, until providers like Bebashi are armed with what they need to actually vaccinate people, we have to arm them with education. And so this is exactly why this platform is here, so that people like me can have a voice and say, we are ready and available when it's available to us. And although we are very small, we're a tiny clinic, we serve the people who are homeless. We serve sex workers. We serve the LGBTQ community. We serve the Black and Latinx community. And the reason that we do it is because we're trusted to do so. And we want people to know that we are a place that is open to everyone without judgment. We certainly will test for people who present with anything that looks similar to it, without the question of, are you high risk? And so we have to continue to have these conversations. And I want to say to Jessica and to Dr. Epstein, I understand that you're representatives. So I want to extend some grace and say, part of what we're doing is giving information to you so that you can take it to the people who need to know that we really want to be sure that we're targeting people with fairly, equitably, and also understanding that there are people who are foot soldiers who do this work, who are willing to do it in a way that really, truly will have an impact on the spread of monkeypox.
Thank you for that, Jasmine, Sabrina, and Dusty. With about 13 minutes left, I'd love to lightning round some questions that are in the chat so people have access to the great panelists who are here from a number of different places. There's one person who is concerned based on their job. The person says, I'm a massage therapist. I'm practicing protecting myself and my clients from communicable diseases, clean surfaces and linens and good hygiene. I always scan each client before working for rash and others. Is there a chance monkeypox virus does not present as a rash, but is still contagious through contact?
That's a really good question. And I definitely hear the concern in that kind of situation. It's, I think you're doing all the right things. Intact skin without any lesion, without any rash is really not where the virus is living. It's unlikely to, get infected that way. But these lesions, again, can be mild and present kind of looking like a typical, like I said, like acne sometimes. Yeah, I really hear the concern and the risk you feel that you're putting yourself at.
There's a question about the different vaccines. How do the smallpox, Dusty, did you want to answer that?
I was just going to also throw in for the massage therapist, wear gloves. I mean, I don't know if massage therapists typically do, but this would be a great time too.
Yeah, I agree with that.
All right. How do the smallpox, chickenpox, and monkeypox vaccines differ from the monkeypox vaccine?
I'm sorry, how do the smallpox and chickenpox vaccines differ from the monkeypox vaccine?
Correct.
So chickenpox is a different type of virus than smallpox and monkeypox. Monkeypox and smallpox are in the same family. So that's a different type of virus. Actually, the difference between the smallpox, the classic smallpox vaccine and this one, there's a lot of differences. This vaccine, Jynneos, actually can also be used to prevent smallpox. So this is a smallpox vaccine in addition to a monkeypox vaccine. The older monkeypox vaccine, the ACAM that you sometimes you still see people with kind of a little scar on their shoulder from, that's a vaccine that was stopped giving broadly in 1972. It's given kind of by poking you a bunch of times with a little needle. It's not a typical vaccine. Has a lot more side effects than the Jynneos vaccine. And it can be dangerous and more dangerous in certain populations. And in those who are immunocompromised, people who have skin conditions like eczema, which so many people have, severe acne, and people who are at high risk for cardiac disease, so who are, have hypertension and a couple other risk factors, not just hypertension, but 3 risk factors are all kind of recommended not to get that ACAM 2000, the older smallpox vaccine. The Jynneos is a much more typical kind of vaccine, kind of more similar to a lot of vaccines we give, like the chickenpox vaccine and some other vaccines that we give currently.
And back to the question of immunity, what is the efficacy rate for the first and second doses? And another similar question, does this vaccine provide immunity or just lower the risk of hospitalization or death like the COVID vaccine?
More great questions that we don't have firm answers to yet. This vaccine has not been used widely, and they're also, you have to have infection to know true efficacy rate, and we haven't, up until the past couple of months, had infection to test this against. The older vaccines for smallpox had about an 85% efficacy rate, so and we have every reason to believe that this vaccine is just as good. But we're, collecting data, the FDA is collecting the data, and hopefully we'll have more information soon. And it does prevent infection, and it also, if it doesn't prevent infection, decreases symptoms. So it does both of those things.
All right. And then in terms of sharing information with the community, how can the public best advocate and increase general awareness about monkeypox to help prevent misinformation?
So I think by working like Jessica talked about earlier, having a coalition of community groups that we're working closely with, who really hear from their own communities and have like a kind of an ear to the ground in their own communities is the best way for us to really learn and improve what we're doing every day.
And then back to the question of protection, someone is asking, what types of gloves should massage therapists wear? Which materials?
Probably nitrile, right, Dr. Epstein? Like, I mean, I would probably go with nitrile, and I would avoid latex, on the, not knowing if your client might have a reaction to that.
All right. And staying on the track of safety and prevention, would places like public libraries where material spaces and more are shared be a concern at this point?
Yeah, that's a good question. Like we've been talking about, we really aren't seeing transmission in those kinds of spaces. It's technically possible to transmit kind of on a surface, but just much less likely. We're really not seeing it. So it's really those places where you're kind of bumping up skin to skin with other people that are the highest risk spaces and situations. If you're taking care of someone where you're kind of in very close contact with them, same idea.
And we have a clarifying question that I think gets at some of the confusion around when to get the vaccine. And here's the question. If you can get symptoms within 2 weeks of exposure, but you're also eligible for the vaccine within 2 weeks of exposure, can you receive the vaccine if you have any potential symptoms?
So yeah, so no, if once you have the symptoms, there's really no reason to vaccinate. The vaccine won't do anything for you at that point. So it's a little bit of a race against time. You really want to try and get the vaccine as soon as you can after that exposure.
And then back to questions about appointments to vaccination. Someone asked, should people call Philly 311 to get appointments from the health department for vaccinations?
I don't think Philly 311 is set up for that. Double check. I think our call center right now is really doing making all the appointments.
All right. And then we're getting more questions about protections. How long does protection last? Years, question mark?
We think so, but again, that I think remains to be seen a little bit.
And there's a question about contact tracing. If you had ideal resources, would you like to see a contact tracing network in place? And if there is one in place, can you talk about that?
So contact tracing is happening as a part of case investigation. So when cases are reported into the health department, they are assigned to investigators. Those investigators follow up with the cases, try to get information about contacts, because ideally we want to get in touch with those contacts as soon as possible so that we can offer the post-exposure prophylaxis vaccine that Dr. Epstein was just mentioning. So I think we have that in place right now. This is a smaller effort right now than what we saw during COVID, and some expansion has been happening within the health department just to make sure that the case investigation keeps up with the pace of cases.
All right. And with the time we have left, I just want to open it up for closing comments to our panelists. I know a lot has been discussed. Just what are some of the takeaways that we should leave people with? I'll start with our friends from Philadelphia Department of Public Health. What are the takeaways that we should leave people with today?
I can start. So I think we want to leave people with the knowledge that, yes, this virus can infect anyone, and anyone who sees a rash should seek out medical care, talk to their doctor, their nurse practitioner, PA, and find out if they should get tested. And testing is commercially available, and we really want to get that testing done so we can really get the best idea of who's affected and protect the people that need to be protected. And I'll just also say again, thank you for having us here. The opportunity to talk to all different providers, groups that are really doing this important work and have the trust of the community is so important to us.
I would just add to that, again, thank you so much for having us. I heard a lot of feedback tonight. We understand that there's frustration, and we are going to take that back to the department, think about how we can refine strategies, hopefully build some other forums where we can do some sharing and hear back from organizations about how we can communicate what we need to be doing, thoughts about how we can expand equity. So this is a work in progress for us. And I think we heard a lot of really good concerns tonight. We definitely heard some frustration, want to take all of that back to the department and really work on refining our strategies as we move forward.
Thank you for that. Sabrina?
Well, again, I say thank you for allowing us to speak. We are open, as I said, to getting information about how to educate the folks that we serve, and ready to disseminate the vaccination when it becomes available. Also want to make note of, just continuing to take note of how these things impact the community at large. We just went through this, and I'm not sure that any of us seems any the wiser. It's like each time we're hit upside the head, like, oh, here we are again, where we want to make sure that we kind of close some of those gaps in the future and continue to have these conversations, even when there isn't something in the midst. So I appreciate you bringing us together, Sultan, and I appreciate everybody being a part of this conversation.
Thank you for being here. I appreciate your partnership. Jasmine?
So at the end of the day, it appears that our federal government has learned nothing. I'm very disappointed in city officials that was on this call, and I'm just disappointed. I would hope that by now we would have figured out that the stuff that was being spoken on this call would be more in tune with what is needed, as opposed to just trying to push this one narrative. But you know, it is what it is. I encourage any attendees who want to learn more about this struggle, or even interested in joining up with us, because this is going to be a struggle. We're going to have to fight to get the vaccines that's needed for everybody. So please find our website, backedupphiladelphia.org. Send us a message. We're always looking for new people to come and join this fight. And not many people have the experience that we have with dealing with pandemics like this.
Thank you for being here, Jasmine. Dusty?
Again, thank you for the open conversation to everybody and anybody who came. Yeah, similar, you know, we don't really know what the landscape's going to look like moving forward, but it's definitely, we're definitely not going to be able to prevent all of these cases. And I think we need to use whatever resources we have, whatever trusted sources of information we have within the community, whatever those pillars are, we need to be, you know, kind of relying on them right now. And we all need to be using our, you know, our own individual voices for public advocacy around access to vaccine, because, you know, as we've seen many times, like that's how we get out of this. So, you know, we just need more vaccine.
Thank you for that. And I just want to close by thanking Rep. Kenyatta and Rep. Sims, along with the many other community organizations and leaders that joined us today, including the Philadelphia Department of Public Health. Our goal today was to provide more information, to have a really diverse conversation from diverse perspectives. And so thank you for the varying perspectives that were shared today, both in terms of the presenters, but also in terms of the questions that were asked. We'll definitely be providing more information to the community about this as the situation evolves. And I just want to close by thanking everybody for taking the time to join us today. Have a good night.